This Grand Rounds clinical case study presentation is going to be on abdominal aortic aneurysms. At the end of this presentation, readers will be able to identify signs and symptoms of an abdominal aortic aneurysm, discuss diagnostic interventions used to identify a AAA or suspected rupturing, identify common etiologies that contribute to the development of a AAA. Presenting illness. A 61-year-old Hispanic male presents to the emergency department with a chief complaint of left-sided groin pain with a sudden onset of 30 minutes prior to arrival. He describes the discomfort as a tearing sensation to the left side of his groin that radiates down his left thigh and leg. The patient states that he is not able to ease the pain with position changes and that the pain is a constant 10 out of 10. He has a past medical history of hypertension and a known abdominal aortic aneurysm measuring 5 centimeters. He's prescribed 100 milligrams of metoprolol succinate extended-release tablets. However, he has not taken it in over 5 days. He has no known drug allergies. Family history shows that his mother had hypertension, diabetes, and died from a stroke at the age of 68. His father had Marfan syndrome and died at the age of 60 from a sudden cardiac arrest. Social history shows that he's a retired construction worker. He's married and lives at home with his wife. He smokes a pack of cigarettes every 3 days, denies drinking at any occasion, and denies recreational drug use. A review of system shows that the patient denies night sweats or recurrent fevers or dramatic weight loss in the past 6 months. He denies changes to his eyes or vision, such as double vision or the use of corrected lenses. Cardiovascular yields that the patient states he feels as though his heart is beating quickly and he feels weak. The patient denies shortness of breath or coughing. The patient denies abdominal pain, nausea, vomiting, or blood in his stool. However, he does report as though he feels his stomach is beating as fast as his heart is. Genitourinary yields that the patient denies frequent or difficult urination or inability to maintain urinary stream. Musculoskeletal shows that the patient relates pain to the left side of his groin, radiating to his thigh and leg. Neurological, the patient denies dizziness, syncope, difficulty walking, forgetfulness, or seizures. And endocrine, the patient denies frequent urination, excessive thirst, or weight loss. A physical assessment shows neurologically the patient is awake, alert, and oriented to person, place, and time, and his gait is normal. Cardiovascular shows that the patient is tachycardic with a heart rate of 127, and he is hypotensive with a blood pressure of 91/61, and he has a bounding carotid pulse. His respiratory system shows clear breath sounds bilaterally, symmetrical chest movement, and a midline trachea. Gastrointestinal yields a pulsating mass noted below the patient's umbilicus. Musculoskeletal shows no bruising at the groin or legs. Skin yields that the patient is cool, clammy, and diaphoretic. The patient's vital signs show a blood pressure of 91/61 with a MAP of 61, a heart rate of 127, a respiration rate of 27, an oxygen saturation of 94% on room air, and a temperature of 37 degrees Celsius. A HENT assessment shows that the head is symmetrical, his pupils are 3, round, and reactive, his nose is symmetrical to his face, and his throat is intact. Genitourinary yields that the perineum is intact, no tenderness noted on palpation to the left side of the patient's groin. Risk factors for this patient would be that he has a history of hypertension and he is not compliant with his medication regimen. He has a known history of a AAA and he smokes a pack of cigarettes every 3 to 5 days. The pathophysiology of an abdominal aortic aneurysm is an enlarged area in the lower part of a major blood vessel that supplies blood to the body. The aorta runs from the heart through the center of the chest, and abdomen, supplying blood to the distal extremities and organs. The aorta is the largest blood vessel in the body, so when a AAA ruptures, patients can lose large amounts of volume at a rapid rate. The mortality rate after the rupturing of a AAA is 50 to 80%. The etiology of a AAA. High blood pressure. Poorly controlled hypertension can weaken the walls of the aorta over time. Hardening of the vessel wall occurs when plaque or fat adhere to the walls of the blood vessel, diminishing blood flow and creating a false lumen in the vessel. Genetic predisposition. Hereditary vascular diseases such as Marfan syndrome causes weakening blood vessels, placing these individuals at an increased risk for a AAA. Other factors include gender and ethnicity. Tobacco smokers are also at a higher risk for a AAA because nicotine weakens the vascular system walls over time. The pathogenesis. In an abdominal aortic aneurysm, matrix metalloproteinase and their inhibitors cause changes to the amount of elastin, collagen, and glycosamine glycans that are present within the vascular system. In the process of a AAA, inflammatory cells are added to the production of the matrix metalloproteinase that are circulating. The constant production causes the vascular walls to weaken. Because of the lack of elasticity forming agents like elastin, collagen, and glycosaminoglycans, a lack in the production of these vital components will cause dilation in the diameter of the vessel and eventually a rupture. A AAA triggers an inflammatory response in the body as well as in the arterial walls. Neutrophils and macrophages are the first inflammatory cells to respond in the vessel. B cells and T lymphocytes are abundant in the walls of the aneurysm. The depletion of B cells help protect the vessel against the formation of a AAA. T lymphocyte depletion attenuates AAA formation. Cytokine production by both the immune cells and cells native to the vessel wall drive the inflammatory response, leading to AAA formation. Cytokine production in both inflammatory cells and the resident cells of the vascular wall contribute to the constant release of inflammatory cells. The constant release of inflammatory cells further weakens the walls of the vessel. Constant turbulent blood flow within the vessel, hypertension, can cause breakdown of the lumens in the vessel wall of the aneurysm, causing a tearing-like sensation for the patient. Ultimately, if the blood pressure is not controlled, the aneurysm can rupture, causing significant blood loss to distal organs and circulating blood volume. The pathophysiology of the disease process, clinical and diagnostic. Clinical, you can see sudden pain in the abdomen spreading to the pelvis, legs, and buttocks, clammy and sweaty skin, increased heart rate. In the presence of a rupturing AAA, patients can feel sudden, intense, tearing-like pain to the lower abdomen and low blood pressure. Diagnostic exams for a AAA would be an abdominal ultrasound. This is a quick way to visualize the aorta in the presence of a known or suspected AAA rupturing. This test can be performed at the bedside. Another test is a CT scan of the chest, abdomen, and pelvis. This is used in an emergency setting to rule out a AAA. It is a very precise test that can show you the location and the size of the AAA. An MRI of the chest, abdomen, and pelvis is performed only if there is a known stable AAA less than 3 centimeters to rule out AAA. An MRI shows an in-depth working of the vascular system and shows a propensity for the AAA to become unstable or rupture. Management. Laboratory findings for AAA, a complete blood count or a CBC with differential may yield a decrease in hemoglobin and hematocrit as well as platelet. There will be an increase in inflammatory white blood cells like your macrophages and neutrophils. Serial blood draws for hemoglobin and hematocrit will gradually decline in the presence of a ruptured AAA. Diagnostic findings as it pertains to this patient, since he was already displaying signs of a rupture with a low blood pressure, tachycardic, and the feeling of a tearing like sensation, an abdominal ultrasound would be the quickest way to identify the tear and approximate the location. So, an abdominal ultrasound will examine the blood flow through the aorta. Visualization may be difficult if the AAA has ruptured and the patient has blood leakage in his abdomen. The CT of the abdomen and pelvis will visualize the full extent of the AAA, including size and location, and an MRI will allow for a more in-depth view of the vessels and identify abnormalities in the vessels that can lead to the formation of a AAA. So lab findings and imaging findings for this patient yield that his WBC count was 7.1, his initial hemoglobin was 8.6, and hematocrit was 25.5, and his platelets were 90,000. So he was already low to begin with. Ultrasound imaging of this patient. The patient identified the sensation of a tear to the groin suggestive of a possible rupture. A bedside ultrasound will be the quickest diagnostic exam. The ultrasound shows a dilated abdominal aorta greater than 5 centimeters with free fluid, suggesting a tear in the aorta at an unknown location. Pharmacological and non-pharmacological management. Pharmacological management includes blood pressure management. Using a beta blocker is a first-line treatment for heart rate control and blood pressure management in patients who are hypertensive. A commonly used medication in the emergency setting is called Brevibloc. Pain management includes the use of opiates like morphine and Dilaudid to help control the patient's blood pressure in conjunction with the blood pressure medication and for symptomology management. And then fluid resuscitation replacement for volume loss is essential, especially if they are rupturing or suspected to rupture. Replacement includes blood products such as fresh frozen plasma and isotonic solutions like normal saline. The only definitive intervention for a AAA or the rupture of a AAA is surgical intervention. It's the most common treatment for an unstable AAA or suspected rupture. The application of a fenestrated graft is placed within the vessel to strengthen and prevent it from rupturing. If the vessel has already ruptured, the surgeon will attempt to repair a tear in the vessel and evacuate any free fluid present. Health promotion and teaching. Health screenings increase with age. With some patients, AAAs are found incidentally. Patients with known hereditary risk factors must have a complete health screening done by their primary care physician yearly or more frequently as it pertains to their risk factors. Education must be done for these patients to help them identify their risk factors and be more likely to come in to their primary care doctor to be screened. Another educational topic would be hypertension and how to manage it properly. Poorly managed hypertension is a main cause for the development for AAA. So, blood pressure management and completing your medication regimen as is prescribed by your primary care physician is very effective in maintaining and managing a healthy aorta. And then smoking. Smoking cessation is very important because it puts patients at a higher risk regardless of their other risk factors. So cessation education is a step towards health promotion for individuals who smoke. Resources like brochures, group or individual educational sessions for cessation can decrease individual risk.